Welcome to the Nutrition Screening Initiative Determined Checklist and Senior Malnutrition webinar. This webinar is provided by the National Resource Center on Nutrition and Aging. My name is Linda Netterville, and I'm Vice President for Program Development and Impact at Meals on Wheels America and Project Director for the National Resource Center on Nutrition and Aging. Meals on Wheels America provides these educational webinars as part of a cooperative agreement we have with the Administration for Community Living and Administration on Aging. Your lines are muted during the webinar to reduce background noise. We encourage you to ask questions throughout the webinar. We will allocate some time to answer questions at the end of each speaker presentation. You can do that by typing questions or comments through the Q&A function on your control panel. You can find the Q&A box by expanding your control panel by clicking on the orange bar with the white arrow in the upper right-hand corner of your screen. With your control panel open, just type your questions and comments into this box and press send. We will be monitoring your questions and comments throughout the webinar. The handout link will be copied in the question box. We will also send the link to the handout in a follow-up email later today. So it's with great pleasure I would like to introduce our two speakers for today. First of all, we're going to have Holly Grueling, who is the National Nutritionist for the Administration on Aging at the Department of Health and Human Services within the Administration for Community Living. Holly has been in this position since August of 2012. Prior to ACL, she has been working for more than a decade with the Florida State Unit on Aging as the nutritionist for the Older Americans Act programs, where she administered the following programs: the adult portion of the CACFP, the Senior Farmers Market, and during 2009 to 2012 worked with those USDA programs. Earlier in her career, Holly practiced in many different healthcare settings to include military, acute long-term care, and home and community-based care settings. Her experience also includes institutional, corporate, and military institutional food service and clinical dietetic management. Also, the second part of this webinar will be presented by Jeannie Blankenship, and she's a registered dietitian with the Academy of Nutrition and Dietetics, where she is the Vice President of Policy Initiatives and Advocacy. Her advocacy work focuses on professional issues for dietitians and nutrition professionals, and includes coverage and reimbursement for medical nutrition therapy, nutrition informatics, and workforce demands. Jeannie also oversees state government relations, including consumer protection and licensure initiatives, grassroots advocacy, and regulatory affairs. She manages the Academy's Political Action Committee, Legislative and Public Policy Committee, and the Consumer Protection and Licensure Subcommittee for the Academy. So it's great pleasure that she will be presenting the last part of this webinar. So now I'll turn it over to Holly to start the first part of the presentation. Thank you. Holly?
Thank you, Linda. This is Holly Grueling, and I want to thank you all for joining us on this webinar. I'm pleased that you have taken the time to join us as we discuss senior malnutrition, the Older Americans Act, and the Determined Checklist. I do want to acknowledge that while this may be old news to some of you, it is new information to several of you. So I appreciate your graciousness as we explore and discuss this topic. Next slide, please. We all know that the program that we are serving in now is way different than the program from the 70s. Our changing demographics are changing how we do business, where we do business, and when we do business. We're not going to discuss all these different aspects of it, but I did want to acknowledge that the program that we have today or tomorrow will look different than the program we have had in the past. There is room for all types of programming, but because our population is increasing, the aging population is expanding in numbers and diversity, we too are going to have to accommodate those changes. Next slide. Before I get started, I just wanted to talk a few minutes about our participants that we have. The congregate nutrition services participants, the average age is 76 years old. Even though the program eligibility starts at 60, we see on average a bit older of a population. So we are not seeing in the masses the young 60-year-olds. We're seeing those that are 75 and older for the most part. We also see that through the survey that we do every year, and the 2014 is the most recent year that we have data, 77% of the participants surveyed said they eat healthier as a result of the meal program. So I know sometimes we all curse the DRIs and DGAs, but it is a healthier way to eat. And again, we're not going to talk about this during this discussion, but the participants on the most part feel they are eating healthier. And then 76% of our congregate participants feel that their health has improved because of their participation in your program. And we know that the meal is just the initial draw to get people in, and that our congregate programs are not just a meal. It is health promotion activities, volunteering opportunities, friendship, decreasing isolation. So it is more than just a meal. And I know we say that, but sometimes we have to talk about what exactly it is. As a dietitian with more than, well, close to 30 years experience, you know, a meal, you could put a meal in front of someone, but we all know if that person is depressed, or if that person is in pain, or if that person has some other issues, they may or may not consume the meal. So getting the nutrition inside someone to help their nutritional status is vital. We are more than just handing out meals, and our programs are more than just a meal. On the next slide, our home-delivered meal participants, the clients we serve today are older. The average age is 79 years old for the home-delivered meal participant. And participants are a little bit more acute than they were in the past. As a dietitian that has worked in skilled nursing facilities so long ago, some of the clientele that I saw in the nursing homes in the 80s, in some areas are the people that you are serving in the homes now. The acuity level of the homebound participant has become very frail and obviously vulnerable, yet through our programming and other assistance, they are able to age in place. It's interesting to note that 42% of our home-delivered nutrition program services participants actually have 3+ ADLs, which, as we all know, is nursing home placement level. So people are staying home even though in the past they could have been or would have been perhaps institutionalized. The program, as we know, provides a wholesome meal to the frail and vulnerable in our community. However, again, the meal is just the key to get into the person's home. But the program offers so many other unfunded wraparound services. We know that deliverers, meal carriers, or volunteers sometimes will see Mrs. Smith, and a particular day she is a little bit unsteady on her feet that day. Well, that driver notices this and actually calls the manager of the nutrition program, and generally that nutrition program manager makes contact either with the participant's family or perhaps the physician. So these are all these wraparound unfunded services that we're providing that are keeping people in their homes. There was a recent study, More Than a Meal study. MOA did it, and it's a very good study if you haven't already seen it. And this is just one of a 3-part series that they're doing. But they showed that home-delivered participants receiving a daily meal worried less about their ability to stay in their home, felt less isolated, and actually had fewer falls or fear of falling, which is significant, as we know how devastating falls can be. And then lastly, 91% of participants indicated that their home-delivered nutrition program helped them stay in their own home. That is vital. And I know it's not said enough, but what you all do in the field is so important to the client, to the community, and to the government. And I just want to express my deepest gratitude, because I know that every single one of you go above and beyond. And we know that, and I appreciate it. We all appreciate it. Again, more than half of our participants live alone. Next slide, please. This is just a subject heading about malnutrition. This whole conversation that we're having right now is about senior malnutrition, but I just wanted to get some of the definitions out there so that we're all understanding where we're coming from. On the next slide, malnutrition, although it sounds like it's a very significant thing, it happens, and it's happening in your setting in our country dramatically and probably right under your eyes. In our country, we're not probably going to see the skeleton of a person, or the skeleton with the very big belly that you see in the pictures of some third world country starvation. That is obvious, but in our country, we're going to see the more subtle signs of malnutrition. But malnutrition, the word mal, when you put it before any other word, but in this particular situation, nutrition, when you put the word mal, it means bad or poor or without. So, for example, malabsorption means poor absorbing. Malformation is poor or bad formation of whatever it is describing. So malnutrition is without, bad, or poor nutrition. It is, there are different degrees of malnutrition, but I can guarantee that when this webinar is over, you are going to know or notice maybe more participants in your settings that are malnourished. On the next slide, the basic definition of malnutrition is a nutrition imbalance that affects both overweight and underweight individuals. I encourage you all to please remember, you cannot judge a person's nutritional status by their body weight alone, unless, of course, they're skeletons. But an overweight or obese individual, although they may have a lot of subcutaneous fat or a lot of weight on them, they could actually be malnourished. So it is, malnourished is the presence of 2 or more of the following characteristics: either inefficient calorie intake due to a disease process, or perhaps depression, or whatever. They're not consuming enough calories. Weight loss, loss of muscle mass, loss of fat, subcutaneous fat, fluid accumulation, and then diminished functional status. This is the clinical definition of malnutrition. And we're going to talk a little bit about what it could look like in your setting. On the next slide, these pictures here, what does a malnourished person look like? There's a lady on the left and a man on the right in this slide. The lady on the left, if you were just to look at her, from her very thin extremities, one would suggest or consider that this individual is malnourished in one situation or another. However, we don't know until we do an assessment. The gentleman on the left, even though he has a fair amount of subcutaneous fat on his body, we don't know his functional status, so we can't really tell if he is malnourished. On the next slide, I went through a few ideas on what malnutrition may look like or may physically appear as. They could have, their skin could easily bruise, or there could be a rash. They have puffy feet because of the fluid accumulation, sunken cheeks because of lack of subcutaneous fat, sunken temporal regions, excuse me, poor fitting dentures. If someone loses as little as 5 pounds after they get their dentures don't fit as well, and they could be loose. Individuals sometimes get cracks at the corner of their mouths. That's usually a vitamin deficiency. They could have the appearance of the loss of muscle mass, particularly in the upper arms. Sometimes people refer to these as bingo wings or chap flaps. Just a little note to the audience that after the age of 40, we all lose 1 to 2% of our muscle mass every year unless we actively do strength training. So those bingo wings affect all of us. You could have the appearance of weight loss. If you notice that an individual is losing weight, that their clothes are more baggy, or if they have dry, very dry, or chapped lips. On the next slide, this may be an easier thing for you to see in the congregate meal site arena. If an individual has a difficulty getting up without assistance from the arms on the chair or the table, if they can get up and stand up without using their arms, this is what this is referring to. Or if they have poor grip strength when you go to shake their hand, do they have a weaker grip than you would have expected? Of course, they tire easily, and they can't stand for long durations. We know that malnutrition affects 1 out of 2 older adults. So I know each of you know people that have these issues, and now that we are becoming more aware of it, I'm hoping that you will start cueing in on some of these areas. On the next slide, screening versus assessment, I just wanted to go over just again the basics of the terminology that we're using so that we're all on the same page. On the next slide, it talks about nutrition screening versus nutritional assessment. The screening is just a fast and simple method to triage patients or differentiate those individuals that maybe have no problems nutritionally or those that do. It is there to help you further determine whether additional information or resources should be used to assess their situation. The assessment, our programming uses the Determine checklist, which is a screening tool. It is not an assessment tool, and we're going to talk about this on the next slide. But the assessment is, in some arenas, it used to be much more of a clinical setting, something that's done in the clinical setting, whether it's inpatient or rehab or institutional, skilled nursing facilities, whatever. But because our continuum of care is including the home and community-based services, we may want to start becoming aware of it and perhaps consider how we can address these issues. And Jeannie's going to talk more about that later. On the next slide, these are the 10 questions that are from the Determine checklist that every one of you use right now. It's a nutrition risk score, or it's a risk, you're assessing their risk for malnutrition. For those of you that that have this embedded in your assessment. This is asked of every congregate, home-delivered, and nutritional participants that receive nutritional counseling with Older Americans Act funds. Anybody that receives 6 or higher is considered at high nutritional risk. But remember, this is just a screening tool. Early detection of those at risk of malnutrition can lead to early interventions, which is way more cost effective. We need to start using these terms and this terminology when we talk to our healthcare partners, because we are already screening them. In 2014, of the 2.4 million individuals that we served in the nutrition programs, we had over 700,000 older adults that were at high nutritional risk. So we have a fair portion of our population that we're serving. And just for those of you that don't know this, we touch the lives of 1 out of 5 older individuals in our country. So we're seeing 20% of the population. Now, the nutrition program doesn't see that much, but the Older Americans Act as a whole does. On the next slide, it's titled Action Steps, and I want to say that these are action steps to increase awareness of senior malnutrition and hopefully help us explain the continuum of care to ourselves, to our partners, our healthcare partners, and to our participants. So on the next slide, I talked a little bit about how to share your programs, what you already are doing. So you could share the number of your participants that are at high nutritional risk. If your program goes above the requirements, way above the determined checklist, then you are assessing and hopefully reassessing those participants at a high nutritional risk, and you could share the outcomes of your interventions. And if you aren't going over and above the determined checklist, then I would encourage you to consider how you can work that into your services. The Older Americans Act does pay for or does allow nutritional counseling. And in some situations, that may better serve a person than a meal. So we have to be judicious how to use the Older Americans Act funding. So on the next slide, that's titled Want to Get More Involved. We're asking that you print and share the following senior malnutrition poster within your agency, or perhaps where older folks may congregate, in the grocery stores, churches, whatever. It's a fantastic poster that just kind of cues people into the basic concepts of what may lead to malnutrition. But if you would also share what you are doing and how the services that you are providing are mitigating the incidence of malnutrition. Because the services that you are giving, the meals plus the activities plus the informal safety check, all the stuff that you are doing, this is all helping to decrease malnutrition. And Jeannie is going to talk a little bit about the cost of malnutrition while we're in the hospital. But just know that what you are doing is helping the overall healthcare dollars. So on the next slide is ask about your nutrition. That's the poster that we're asking you to post, especially during Senior Malnutrition Awareness Week, which is the end of September, the last week in September. But the last slide, the last slide that I have, I just want you to know that the Older Americans Act generally functions in the self-care and the community-based care arena. However, healthcare extends itself into the acute, obviously, the inpatient units, but also into the community. So we know that many hospitalized older individuals are admitted with an underlying malnutrition diagnosis. That means they're coming from the community malnourished. And as we know, malnutrition exacerbates any and all conditions. We need to become aware of how good and adequate nutrition is vital to helping older adults remain in the community and also decrease healthcare costs. Right now, healthcare doesn't have a clear process for diagnosing malnutrition, but they are working on it. When this is, and Jeannie's going to talk more about that and tell you how soon this ball is rolling. So when the aging network must be ready when the malnutrition is a routine diagnosis in the hospital. And also when doctors realize that malnutrition must be addressed after discharge, because we all know hospitalizations is a very short period of time. So it is in everybody's best interest to ensure that malnutrition or malnutrition status is addressed. And again, as I've said before, malnutrition isn't just because they don't have good calorie intake. It could be because they're depressed, because they're isolated, or they're physically unable to cook, or all sorts of things. I don't need to tell you all, but it is way more than just putting food in front of a person. The physical interaction with others is important. And lastly, I want to say that, I want you all to better understand where the healthcare is going, what our pieces are. We have a bright future. Home care is the future. We are already doing a lot to support healthcare and keeping people healthier. Jeannie is going to talk a little bit about what's happening in the inpatient units and where maybe the bridge is, how we can bridge over. And I don't know if we have time for questions. The second to last slide is my references, and then, of course, my last slide is the thank you. So, Linda, do we have time for questions?
Yeah, we do have we have quite a few questions, and so we'll try to answer as many before we turn it over to Jeannie, and then at the end we'll try to get the rest of the questions, and then we will address the questions when we send out the link to the presentation too. So the first question that came in, did you say that malnutrition is 1 out of every 2 seniors? Can you clarify?
Yes. And Jeannie's going to share a handout that has this information on it.
Okay, great. And then the next question, we use the screening tool, but the question about weight gain or loss is desired or beneficial to the client. Going more in depth would be beneficial in the medical community. Is there any plan to make this more useful tool for outcomes for our programs?
Well, that's a very good question, and this is a broad area, and we are looking at all aspects of it. But I can tell you that the information that we require at the federal level is different than the information that you require at the local level. We cannot ask for client-specific information, obviously, but we need characteristics of our clients. So while we just want to know a snapshot, it is in your best interest to investigate other areas that would give you outcomes. And if you look at some of the references that are listed, especially the Aspen reference, there are other nutritional screening tools and nutritional assessment tools that have been validated that would give outcomes. So that's an excellent question.
Okay, thank you. Just a couple of quick ones here. How do you get the posters, the poster that you referenced?
I'm hoping you will go to the Aspen website and download it. I can't, there's nobody that's offering to print it and mail it.
Okay. And then just to mention that the handouts and PowerPoint will be available online. The link will be sent to the participants after probably tomorrow. We will have that all ready to go for you all. So, okay, just so that we have plenty of time for Jeannie. Jeannie, are you ready?
I am ready.
There we go. Okay, I'll turn it over to Jeannie Blankenship from the Academy of Nutrition and Dietetics for the second part of this presentation.
Go ahead and advance the slide.
Okay, advance the slide. There we go.
Thank you. Well, thanks everyone, and thank you, Holly, for asking me to present today. I'm really excited to be able to talk to this group that I know you guys are making such a difference in the lives of our nation's seniors. I echo Holly's sentiments about the great job that you do, and we know that you need more resources and that you really want to serve this population. So again, hats off to all of you. I just appreciate the work that you do, and I hope that today's presentation will bring even more awareness not only to your work, but to the opportunities that lie ahead. So let's go ahead with the first slide. Holly talked about malnutrition and the definition, but I just wanted to reiterate that it does affect both overweight and underweight individuals. So I thought she did a nice job of outlining that. It's very subjective to look at an individual and make a visual assessment of their nutrition status. It is so much more than that, and I hope all of you come away from this knowing that that jumping to conclusions is part of the problem that we have with understanding the importance of nutrition and the role that registered dietitian, nutritionists, and others play in uncovering the true malnutrition risk and status. I cannot tell you how many times I've read physician notes that begin with, Mr. X is an 89-year-old well-nourished male. Is he? The physician has likely made that conclusion without even considering what information that is objectively provided that has been identified by other healthcare team members. So really, again, we can't leave this to a subjective visual assessment. We have to make sure that we're doing due diligence to move beyond just that subjective interpretation. Holly also talked about the diagnosis of malnutrition, and according to the consensus statement, which is referenced there from the Academy of Nutrition and Dietetics and ASPN, which is the American Society of Parenteral and Enteral Nutrition, individuals need 2 of 6 criteria listed to meet that threshold for diagnosis. Holly also mentioned the physical findings that are consistent with malnutrition. I would highly recommend that nutrition professionals consider attending a nutrition-focused physical exam training. This is something that's been done over the last couple of years. You can watch for them in your local area. At this point, when hospitals, groups, or entities have enough people that are interested, the workshop is offered. It is very hands-on. It includes, again, looking over an individual, doing a complete physical exam, but it takes it a step further than most of the registered dietitian nutritionists who are trained have had. So again, that would be something that I would recommend if you're interested in really getting into this area of malnutrition. Let's go to the next slide. So you might have noticed today, go ahead and advance the slide. Takes a little bit of time on the delay. You might have noticed that in my presentation, I kind of tongue-in-cheek noted that it was the new senior crisis. And the title then is similar to this article, which was written by my colleague and yours, Bob Blancato, who, among his many hats, also serves as the national coordinator for the Defeat Malnutrition Today Coalition. Bob's article here brings to light the issue of malnutrition, and although it's new to some, I again say that with tongue-in-cheek. We all remember that in 1974, Dr. Charles Butterworth's article, Skeletons in the Hospital Closet, brought malnutrition to the forefront. I'm again going to say that date, 1974. We have made seemingly little progress in the past 40 years in changing the system so that ignoring malnutrition becomes both unfathomable and unethical. And I apologize, I'm in Washington, D.C. downtown, and there's fire trucks and ambulances going by. So that is until now. We have to wage a strategic, evidence-based, collaborative war against one of the single remaining health conditions that is left unrecognized and untreated. We simply need to do this. Next slide. I'm going to pause just for a moment while my fire trucks pass by.
And also, Jeannie, there are a couple of people that have indicated that they're having difficulty hearing you over the fire trucks. So, if you could speak into the phone better, I think maybe, along with the fire trucks going away, that will help. Thank you.
I'm wearing a headset, so I don't know that I can do much better than where I'm at now. I apologize.
Actually, you're better now, so good. Thank you.
So how bad can malnutrition be? And I know someone brought up the 1 and 2 older adults. This is a really nice infographic which can be found on the Defeat Malnutrition Today website. I think it does a nice job of providing compelling statistics about malnutrition. It's a very useful tool if you're having conversations with other providers or stakeholders, policymakers. There's another version also on the website that's a 2-page version that splits the information that you see here into 2 separate pages. But let's look at a few of the statistics. Up to 60% of older adults admitted to the hospital are already malnourished or at risk of malnutrition. Up to 60%, that's a huge number. In addition, 35 to 50% of older residents in long-term care facilities are malnourished. Why is this concerning to us? Well, if you look at that first bullet up there, the first square, $51.3 billion are spent in the U.S. per year just on this elderly section of malnutrition. So that doesn't include the greater than 100 billion more that's spent on all age groups. But there's a big gap here between the identification of malnutrition and the treatment, and that's having a significant impact on healthcare costs. While malnutrition is preventable and very costly, it's very prevalent and potentially costly, it is also very preventable. I think, again, this tool can be used when you're talking with stakeholders and have this conversation about malnutrition, just open the door for future solutions, if you will. On the next slide, this slide shows you, there are many reasons why individuals become malnourished, but it's the relationships here, not necessarily all of the factors that would contribute to malnutrition, but these are very familiar to you. The very programs that you manage and direct address food insecurity and hunger for our nation's seniors. And while these programs have the incredible opportunity to address both food insecurity and hunger, as Holly noted, food alone will not always prevent, and it definitely will not treat malnutrition. That's the challenge we face, how to address true malnutrition and provide the services and resources that are needed to prevent hospital admission or to continue a care plan after discharge. We're going to talk about data a little bit later in the presentation and to identify some ways that we might be able to do a better job there. I know all of you recognize that challenge, and I'm also aware that you're part of the solution, so I'm looking forward to how we can make the bridge between some of the work that we're doing on these quality measures that I'll talk about and the work that your groups do. On the next slide. So again, nutrition risk is the what could be aspect of nutrition when we talk about the determined checklist, and one of the questions that came up had to do with the other care settings and other ways of identifying risk. There are several validated tools that are available for identifying nutrition risk, but as I will note later, they're not routinely and consistently used in the hospital-based systems. And then nutrition assessment is really that point in time. So once you've determined risk, the assessment will define the nutrition status and ultimately allow for the not only nutrition diagnosis but the medical diagnosis of malnutrition to be made. So once we start looking at the steps that are needed to identify, diagnose, and treat, you can see that if we have breaks in that chain of events, that the quality of healthcare is going to be impacted. So then on the next slide, Of the roughly 36 million hospitalizations in the U.S. each year, we know that, again, between 15 and 60% of the patients are malnourished, and yet we're only diagnosing about 3%. So that means we have somewhere between 14 and 19 million cases that are left undiagnosed and therefore untreated. Seriously? I mean, we can do better here. The lack of consistent screening with a validated tool, the lack of diagnosis and treatment plan, and appropriate monitoring are all individually and collectively, and unfortunately, examples of care. We simply can do better. Malnutrition intervention is a low-risk and low-cost solution that can help improve the quality of clinical care and care transitions. The next slide. So what are some of those positive things that we see with nutrition intervention and outcomes? There's a 28% decrease in avoidable readmissions when we conduct that nutrition assessment. These effective and timely screening assessment, it's really essential to help providers make accurate medical diagnoses. Early nutrition interventions and discharge planning have been shown to obviously improve the hospital readmission rate, and prompt nutrition assessment and intervention can also significantly improve other patient outcomes, such as the incidence of pressure ulcers goes down by about 25%. There's a length of stay impact of about 2 days differential between those patients who are treated for malnutrition and those who aren't, and overall decreased mortality. And I'm sorry, on these slides, these arrows jumped around a bit. It's a bit different than what I sent in. And then the total impact of this, if we look at nutrition assessment and intervention outcomes, what it ultimately leads to is an improved quality of life. And I think that's what we all want in all of our different programs for our nation's seniors, is for them to remain functional and independent and to enjoy a improved quality of life. So again, addressing nutrition assessment and providing those interventions can lead to these positive outcomes. So then on the next slide, I want to transition and about a project that we've been working on for the past few years. Several years ago, the Academy began a collaborative project with Abbott and Avalere Health to begin to address malnutrition as a quality issue, and I brought that up on a previous slide. The Malnutrition Quality Initiative Malnutrition Quality Improvement Initiative, it's a little bit of a mouthful, was launched back in 2013. And during the past 3 years, we've gone from conceptualizing the project to identifying a technical panel and collaborative sites to collect data, and then to begin to prepare measures for submission. Sorry, I'm hearing some background noise. I'm pleased to say that during this past summer, we were able to work with these other entities to collaboratively submit 4 de novo or new measures to both the Center for Medicare and Medicaid Services and to the National Quality Forum. We really applaud CMS for the work that they've done to date in terms of advancing policies for improvement of beneficiary access to nutrition care. We've had some great successes over the past few years, but we want to urge them to continue to take the next step to ensure high quality, timely, and coordinated care by formally adopting these malnutrition quality measure sets into their value-based quality incentive programs. So as we look for ways to improve patient care, as entities look for ways to reduce costs, this really could be an answer to some of their quality programs. So again, this can start with this adoption of these 4 new clinical quality measures. They are electronic, and the Academy of Nutrition and Dietetics is serving as the steward, meaning that we'll be the one to oversee and watch the measures as they move forward. And with a little bit of advocacy, some luck, lots of evidence, and collaboration and agreement from many in the healthcare arena, we're hoping to see the inclusion of these measures in the 2017 CMS quality program. Let's move to the next slide. As we started to talk about the project itself and to conceptualize it, we really wanted to develop quality measures that mattered. So if we do certain things, will it impact healthcare quality? Will it make a difference in the long run? Right now, CMS, or for the past few years, they've been focused on process measures. So that is, again, that concept of did something that should have happened either sequentially or over time, did that happen, versus an outcome measure, which is the end result, what did happen. These are process measures, and I think CMS would have liked for us to have been able to be at the point of recommending outcome measures, but we're just, because there hasn't been anything in this malnutrition area, we had to start with the beginning and to, again, develop measures that would help lead us ultimately into outcomes. As part of this project, we really worked on an interdisciplinary team approach, and the test sites and collaborative partners used a toolkit or a roadmap to work on implementation. And it was interesting to see the challenges that different systems faced based on how they themselves had designed their build-outs on their electronic health records, to how their perhaps clinical nutrition was provided, lots of different things that impacted, and it's not a one-size-fits-all when you look at how do entities take a set of quality measures and use them within their own facilities. So that's one of the challenges moving forward. Then finally, these objectives, we wanted to come up with some tools that could be integrated into electronic health record systems that would, again, improve healthcare quality. This focuses on the very population that you serve. It's on senior adults age 65 and older. We've had questions about whether or not pediatric measures are being developed for malnutrition, and there is work in that area, but this particular project really was focused on this patient population. The next slide. This just demonstrates the, I guess, if you will, the process that would be ideal. So looking at the screening using a tool that's validated, then that leading to the assessment and diagnosis of malnutrition, followed by treatment and monitoring. And the monitoring and evaluation component is something I think that links back to the work that you all do after a patient is discharged. The fact that these measures are electronic will help facilitate the interoperability of the data, so that means the ability of one system to talk to the next. We want to make sure that the information that we gather and collect in a hospital system is transferred with the patient. Nutrition in and of itself is not part of the stage 2 meaningful use of when we start talking about the changes with electronic health records, but there are components that are included, and I think setting this up in that electronic environment and the 4 measures together as part of a value set will help us to not only treat patients when they're hospitalized and to monitor and help them with their care plans while they're in that setting, but then also to look at those care transitions, whether they be into long-term care, into subacute rehab, or perhaps back into community-based programs. Next slide. So here are the 4 de novo measures that we have put forward, and really to me they're pretty basic in concept, but they're important. So the first is, first of all, these new electronic measures align with the CMS priorities to address clinical variations in care, to improve patient outcomes, decrease cost, and to reduce burden of data collection for providers. We're trying to make sure that what we do in one setting that we also do in another setting within different hospital systems to try to make the delivery of care consistent and, again, measurable and meaningful. So these are the 4 measures that have been proposed. The first one is the completion of a malnutrition screening within 24 hours. This is not anything new. If you think back to the Joint Commission requirements, you know that as patients enter into the system that we need to do that screening piece. What is missing is that using a validated tool or making sure that the interdisciplinary team that's addressing this has a validated tool to do that. These are often done by the nursing team or other professionals as a patient is entered into the hospital. The second one is if they screened positive for a risk for malnutrition, was a nutrition assessment completed? The next one then is if we did the nutrition assessment, did we develop a care plan and have a system for monitoring the progress towards that? And then finally, is the diagnosis itself documented, and I mentioned before only 3% of cases are documented, so that's a huge thing that needs to happen in order for us to be able to effectively treat patients along the entire continuum of care. That diagnosis really needs to be there. Otherwise, when they go back out into the community, there's no tagging or no significant communication point where community-based programs can see that the malnutrition was addressed and that there was a care plan. So we want to make sure we get that in there. We're hoping that, again, all of these measures will be picked up and added to the measures under consideration list of CMS, and that we're able to move forward with implementation in 2017. Next slide. So here's a few of the key milestones that I mentioned with the project back. We started conceptualizing in 2013, and it wasn't until March of this year that we actually began working with the organizations that would be testing the toolkit and looking at implementation and gathering data. So that's a very useful step in this process because it allowed us to come forward with the measures with some data behind them. We've been working with CMS. It says April 2016, but we've actually been meeting with them for quite some time. And I will tell you that when we first went to CMS and talked about the concept of quality measures, it was almost like a light went on, because the hospitalist that was part of the measures team was looking at 30-day hospital readmissions, and I think they've really tried to look for the unturned stone. What aren't we doing that we possibly could do that could improve patient outcomes and help reduce these readmissions? Because for the most part, if they could address it, they've done so. They've looked at what do we need to do so that we can make they could survive as a business entity. This is an area that they haven't looked at so much, so it was exciting to them to have that conversation. We did submit the measures, as I mentioned, during the summer months, and now we have 2 different initiatives that are going on as a result of those submissions. We do next week have a opportunity to comment with National Quality Forum on these measures. It's an open public comment, so I'm sure that some of you will be interested in the outcomes of that. But as we've looked at what do we do next, there's 2 arms, and the first is an advocacy piece, so continuing to encourage CMS to adopt these measures as well as work with National Quality Forum on endorsement to make sure that these do move forward. So that advocacy piece is one area. The second area is we have to prepare the troops. You know, a lot of the nutrition professionals out there don't have training in the physical findings of malnutrition or looking at the physical assessment piece, maybe not aware of the diagnostic criteria that are listed in the consensus paper. We also have a little bit of advocacy work to do on that diagnosis piece, so we continue to work with CMS on their definitions, submit terminology for inclusion in the electronic health record. But we have to look at opportunities for professional development and training for nutrition professionals and frankly for the entire interdisciplinary team. It's not just about educating nutrition professionals, it's about looking at the needs of physicians and nursing, physician assistant, and nurse practitioners as well as other healthcare providers. So we've got some work to do, and fortunately the project does include that rollout component with Abbott and Avalere, so we're excited to continue to move forward with this. And I think that the advocacy work in malnutrition is something that we haven't done at least recently, so it's an area where there's been a lot of initial interest in helping to move this project forward. Next slide. So what are we doing? And Holly mentioned some of this, but the last week in September is Malnutrition Awareness Week. The American Society for Parenteral and Enteral Nutrition, ASPEN, has long championed malnutrition awareness, and we are proud to be collaborating with them during this week and with the Defeat Malnutrition Today Coalition to bring awareness during this last week. The first thing that we're doing on September 26th is to have an advocacy day here in Washington, D.C. We've planned a congressional briefing that will give an overview of malnutrition, talk about the quality initiative. It will also talk about the disparity aspects with different populations with malnutrition. And then finally, we'll close it up with circling back around to hunger and food insecurity, the safety net programs, the role that they play in terms of preventing malnutrition, and then the role that can be played in the treatment of malnutrition. So just again, looking for bridging that continuum of care. We will conduct interdisciplinary Hill visits after we have our briefing and then have a networking reception at the end of the day. There's also a lot of other events that are happening during that week just in terms of provider awareness and training, so you might watch out for those. We did do a training webinar yesterday for the Academy. We had about 200 of our members on that webinar, and that was training them not only to come on September 26th to meet with members of Congress here in Washington, but to also conduct visits with their members of Congress back in their home states. So we're trying to hit it from both angles, both Washington and in district. And then also during this week, we're working to increase the awareness of the determined checklists and nutrition screening. So encouraging consumers to, even screen themselves to look at, am I at risk for malnutrition, or to bring awareness to other providers that may not be aware of the impact. We have a social media campaign that we are embarking upon with the Academy and working with our partner organizations at the Defeat Malnutrition Today Coalition, so they will also be posting information through their channels. Next slide. So in terms of the ask that we do on the Hill Visit Day, we've written a letter or worked on a letter that we are championing through members of Congress. We've identified a few champions, and they will help us collect signatures from other members of Congress. So it will be a letter from Congress to CMS, and it encourages CMS to move forward with the project and to consider the impact and potential opportunities that exist by addressing malnutrition in terms of healthcare quality improvement. So that Dear Colleague letter is really the focus of our advocacy efforts. We are planning an action alert where members of the coalitions and of our organization can send a message to members of Congress asking them to sign on. We do have the issue brief and message points prepared, so those are available. If you're interested, they'll be posted on the Defeat Malnutrition Today website probably by the middle of the month. We are hoping to have just a little bit more time to finalize things, but we'll be using the infographic that I presented earlier. And then also in the May issue of the Academy of Nutrition and Dietetics, there is an article about the quality measure improvement initiative, that the malnutrition quality improvement initiative, that we are asking those who are doing the Hill visits to read. It gives a great overview. It's very short, probably 2.5 pages. There's the consensus paper available as well as a copy of the letter. So if you want more interest or want more information, that'd be the place to go. But continue to have those conversations. Talk with others about malnutrition with people within your network. I think encourage the continued use of the determined checklist and to just ask, now what? You've identified someone at risk for malnutrition, then what do you do next? How do we bridge that into nutrition assessment, and how do we communicate that information? There's a lot of opportunity. And then finally, if you can submit your ideas and stories, we do have a place with the Defeat Malnutrition where we're keeping a library of stories that we can share with members of Congress and with policymakers, just bringing light to how significant this issue really is. And on the next slide, I'm just happy to take questions that you might have or to send them back to Holly if there's something that's more appropriate for her to answer. Thank you very much for including me.
Thank you, Jeannie. That was really great, and it's good to hear what the Academy of Nutrition and Dietetics are doing. I have a couple of questions. We only have like 1 or 2 minutes, but we'll try to get some of these questions answered and sent out with the presentation. We'll see what we can do. Also, there's been a couple of comments to pass along to you, Jeannie, and to you, Holly, so I'll make sure that you get those also. One question we received was, unfortunately, most of the malnutrition research is on the acute setting side. What is the Academy doing to incorporate, promote research in the home setting? were any of the sites for testing for malnutrition process measures home and community-based services?
That's a great question. So, I mean, I fully agree that a lot of the research has been done there, and and despite it painting a very, terrible picture about nutrition status, we haven't moved. We haven't done anything to really address this. So I think we have the data there, and if we can start anything, it really is the opportunity that we have right now is on the inpatient side, and that's where this quality improvement program lies. So that's why we worked in this particular area. So we didn't go into the community-based programs or home-based programs. We have been actively involved in the, if you're familiar with the Impact Act of 2014, that is the legislation that looks at bringing quality measures and value-based payment to post-acute care transition settings, so looking at acute, subacute rehab, long-term care, hospice, and one other care setting, and I'm not thinking off the top of my head, but looking at the way that we measure quality in each of those settings and trying to make it consistent across all of them. And there are efforts to include nutrition issues in those quality measures, so we've done some of that. But as far as going back to the home setting, I think that's really the next step. And I would say one of the great things about the home delivered meals program at the federal level is just that use of the determined checklist. But unfortunately, we haven't done a very good job of collecting data and reporting out on that. And I think if we had done that and we were able to say, look, this is the number of people that are at risk, it would lead to not only a look at how we then conduct those nutrition assessments, but it would also give us, ability to go back in and have a conversation with CMS about reimbursement for those services when you're not in a hospital setting. So right now, it's like you have to get into the hospital, you have to be admitted for that malnutrition and nutrition assessment to fully go through the spectrum. But what we'd like to see then is if we had enough to say this is a problem before you get to the hospital, let's look at ways to treat it even if you're not admitted to the hospital. That's the gap that we're trying to address now. So I have been having conversations with Holly, and I'm optimistic about coming up with some new models and looking at ways we might be able to work with the accountable care organizations and others to figure out some ways to make some of this happen.
Okay, thank you. Very well said, Jeannie. In the interest of time and keeping this at 4:30 to close, what we'll do is we'll take and send these questions to the presenters and see if we can add some answers to those questions that have gone unanswered, because we have a lot of valuable information here. I want to thank the presenters. Wonderful presentation, and so timely because of Malnutrition Awareness Week that's coming up. I want to thank the attendees. We had close to 400 in this particular webinar, so thank you so much. When you close out, it's very important you will see an evaluation, and if you could complete that evaluation, it helps us in identifying future needs for webinars and program information tools, etc. So please complete the attached evaluation when you close out. And then just a reminder about the recording and slides will be sent to you via email later today or tomorrow. So again, thank you so much, and the links will be provided to you of, I think we had a couple about the posters, Aspen, so on. We'll try to include some of those links that you've inquired about in the handouts that are sent to you later today or tomorrow. Again, thank you so much, and thank you to the presenters. Thank you. Bye.